So, how many of you are aware of, let's start, how many of you are aware of, there are a lot of modalities of managing a sleep disordered breathing beyond a PAP therapy. How many of you are aware of that? With a show of hands, please. With a show of hands, please. Does anyone have any ideas in tailoring a PAP therapy in a patient of obstructive sleep apnea? Suppose if a patient has got a mild obstructive sleep apnea, very mild, or is probably having an upper airway resistance syndrome, would you, is it started? Would you just write a PAP therapy, or think of giving, behavioral modifications? Also thinking of some oral devices, like mandibular advancement devices or a tongue retracting devices and on so on. So my talk is going to revolve around all these things, and then I will touch base upon some of the sleep phenotypes. We all are now in the era of precision medicine. So each and every patient behaves differently, right? We have phenotypes in asthma, airways. We have phenotypes in ILDs, and we also have a phenotypes in sleep breathing disorders. So before I start, I would like to tell you how pivotal and how important is sleep to all of us. And this is a fantastic quote by Mahatma Gandhi. He says that each night when I go to sleep, I die, and the next day morning when I wake up, I'm reborn, right? As I said, but look at this. This man has done everything perfect. He's not left any stone unturned as far as treating of the sleep disordered breathing is concerned. He is a 54-year-old male on 4 drugs for blood pressure. Still, the blood pressure is not under control. He has a heart failure. He's a diagnosed case of obstructive sleep apnea with an AHI of 20. He can't tolerate his CPAP. He has worsening hypertension. He says he can't breathe. His AHI on CPAP has increased. CPAP of 18 centimeters of feels that air does not go. So what's wrong in this man? Now, he has been, meticulously following the advice of the doctor. So ladies and gentlemen, these are my objectives, and this is basically a blueprint or synopsis of the next 18 minutes of my talk. My first objective is we will talk about the perception of the CPAP adherence and the problems of that. Then I would touch base upon various non-PAP therapeutic options. Then we will also understand what are the different types of phenotypes in obstructive sleep apnea. Then we'll talk about the importance of non-PAP devices or non-PAP therapies. And then we will have when do we use an amalgamation of 2 modalities? So a non-PAP along with a PAP. So as I'm repeatedly telling this, not everyone who snores has sleep apnea, right? But then it's also correct that not everyone who has sleep apnea will tolerate a CPAP, right? So this is a fantastic study which shows that all those patients who had negative perception about using CPAP ended up using a CPAP of less number of hours at night, right? This is very important. And let's look at the adherence. How many of us practice sleep medicine? With a show of hands, please. How many of you practice sleep medicine? How many of you call your patients to look at the adherence of the CPAP 2 months, 3 months, 6 months, 1 year down the line? So that's what it is. They would only end up to us when there is a technical problem with the machine, or else whenever they have some symptoms which sprouts up or mushrooms on the machine itself. So otherwise, we are also not bothered whether they are taking it regularly or not. Though there is a smart card which is attached to the device, and it can be probably downloaded and we can see how they have used it, but we don't do it. And if you look at it, if you look at the age-wise graph over here, as the age increases, the adherence decreases. And so what do we do to modify the risk factor in this 25 to 50% of those patients whose perception is poor and who are not very good compliant of a PAP therapy? So this is what non-PAP therapeutic options are, right from behavioral measures, that is weight loss, positional therapy, abstinence from alcohol, opiates, sedatives, some surgical options, and oral appliances, and so on and so forth. For you to remember this is very important, that all this therapy that I'm going to discuss is not 100% effective in a sleep apnea patient. right? So you need to identify that particular patient who's going to have a better option with, will behave better with the non-PAP therapy, or else you probably also have to combine two therapies to make him comfortable and apnea-free. We all know that 30 to 60% of obesity will have a sleep disordered breathing, right? But if the patient is a weight loss, so if there is a 10% increase in the weight loss, the severity of sleep apnea would increase to 32 to 40%. And if there is a 10% reduction in the weight loss, the severity of the sleep apnea would go down to 25 to 26%. And this is a very nice forest plot which shows that with a bariatric surgery, there is a reduction in the severity of the sleep apnea. Let's now talk about some of the positional therapies. And we all know that patients do have positional sleep apnea. And this study shows it is to the, this is a meta-analysis of various studies, which shows it's to the tune of 23 to 70%. And this is a fantastic device which helps in the Can anyone tell me what is positional sleep apnea? I want everyone to remain awake. I'm sure they are serving the teas and the coffees, but probably, everyone is so quiet in the audience. I need to know what's the definition of positional sleep apnea. Anyone from the audience, please? So patient has a sleep apnea when the patient is supine. The moment they turn lateral, their sleep apnea would not be there. So AHI would become normal. Right? In all those patients who has got positional sleep apnea would have a low AHI, would have a low desaturation. They have low, the blood pressures are pretty under control. They have a less tendency to develop a cardiovascular risk. And it is more common in females compared to males. And if you look at, do I have a pointer over here? Look at this device. This device helps in detection of the positional sleep apnea. And it also helps in prevention. How does it help in prevention? Whenever the patient is on the supine, it generates some electrical vibrations, and the patient tends to go on the lateral side. And if you look at this graph, after wearing the positional therapy, there is a reduction in the severity of this AHI. Let's now talk about the surgical options. So this is a comprehensive review of various studies looking at all types of the studies for sleep disordered breathing. And this is a meta-analysis where they looked at the AHI before the studies and after the studies, after the surgeries. And there is a significant reduction in the AHI post-surgeries. This is a new modality which is called hypoglossal nerve stimulation, where there is a cuff which is inserted around the hypoglossal nerve, and it has got an electric stimulation which causes the protrusion of the tongue outside and helps in improving the AHI. Let's now go to the oral appliances. We have tongue retainers and mandibular advancement devices, which would probably increase the pharyngeal airways and also help in repositioning of the bony structures. However, there are pros and cons of this oral appliances. So, the pros and the benefits of this are that it is a portable device, it is easier to manage, and it is less likely to exacerbate the sinus or the nasal sinuses. But the most important thing is this has to be prescribed in only those patients who have mild to moderate disease. This won't work in those patients who have got a very severe disease, right? And then, of course, you can use this with a PAP. You can, mix 2 or 3 things that I'm going to talk in the phenotype though, but only if the patient has mild to moderate disease. Can anyone tell me what is the similarity of this picture? We see everything is so similar over here. Can anyone tell me what is different, what is same? When you look at this, you think, everything is same. And do we need to even bother about finding out what is different in this? And that brings the concept of phenotyping. The phenotyping in each and every disease is very important. 2 patients would behave differently, and that gets the concept of phenotyping in sleep disordered breathing, especially obstructive sleep apnea. So we have phenotypes, we have anatomical phenotypes, we have physiological based phenotypes, we have polysomnography-based phenotypes, we have gender and obesity-based phenotypes, we have positional-based, which is supine and non-supine, as I said, there's a positional obstructive sleep apnea, and then there are varied clinical presentations and varied clinical phenotypes as well. Let's look at this. Both of these ladies, there is an obese lady, there is a thin lady, both of them have a same AHI. So this is an anatomical phenotype. If you look at the obese lady, she has got more of a soft tissue, but a normal bony enclosure. As against that, if you look at the thin lady who has got a retrognathia, has a very bad bony enclosure, but the less and more, normal soft tissue. Both of them have a same AHI. I'm sure there was one, I think you were asking me yesterday, right? That how do we differentiate about the, so this is how it is. This is what I was telling you. So how do you diagnose an anatomical phenotypes? That there are various modalities to diagnose anatomical phenotypes. We do it by cephalometry, we do it by MRI, we do it by cone beam CT, but most important thing is drug-induced sleep endoscopy. And this is going to help us in identifying the exact site and nature of the upper airway collapse. In fact, it would also help us in diagnosing multiple level collapses, right from the posterior nasal area up to the laryngeal areas. And that will probably help us in identifying the real surgical or modality or any other approach. Look at this study where the indication of the surgery changed, because the first indication for the surgery was after the indirect laryngoscopy by an ENT surgeon in an awake state, followed by DICE. The indication changed. So this is how the DICE would probably help in diagnosing the anatomical phenotypes of obstructive sleep apnea. In case of a skillet, we do have a mandible, which is a patient is having, you can use a mandible advancing devices, or you can also have a mandibular advancing surgery with a screw in case of a skeletal abnormality. In case of a soft tissue abnormality, you can do a tonsillectomy, you can use a CPAP pressures, or you can also have three modalities together. Let's talk about the physiology based. So what causes obstructive sleep apnea? So the obstructive sleep apnea is based on four things. Number one is anatomy. Number two is the muscle responsiveness. We have muscles which are around the, in the neck and throat. That's two. The third one is the arousal threshold. And the fourth thing is the respiratory system functioning. Right? So when I'm talking about physiological anatomy, first thing would be arousal threshold. There are so many people who will have a very poor arousal threshold. What do I mean when I say a poor arousal threshold? Poor arousal threshold means that with smallest of the perturbations, there will be repeated awakenings. And when there are repeated awakenings, there are all the chances of fragmentation of the sleep. There are all the chances of increased incidence of obstructive sleep apnea. Then there is something called peak crit. That is a critical pressure. What do I mean by that? A critical pressure which is required to keep the pharyngeal airways open. If peak crit is not there, the pharyngeal airways would be collapsed. How do we manage peak crit? Peak crit is the muscle of the genioglossus muscle, which would probably have more pressure inside, and it will overcome the collapsing pressures of the outside. Right? And then we have most important concept which is called loop gain. Very important thing, you need to know what do I mean by loop gain. Loop gain is a measurement of the respiratory system to the various perturbations. Now, if the loop gain is high, right, then in that case, probably the patients would have more of obstructive events. So, in case when there is a low awakening threshold, people have used sedative drugs to increase the arousal threshold. Whenever there is a high loop gain, people have used oxygen therapy along with drugs, along with CPAP to take care of those loop gains. I hope this is very clear, because physiological phenotype is the new kid on the block, and if you identify this on your polysomnography and from the history, this is going to help you in chasing a very different phenotype of the patient. Is there any question regarding a physiological phenotype? And this is what I was talking about, the PALM approach. The peak rate, the arousal thresholds, the loop gain, right, and the muscles. Okay? Let's talk. So this is how it is. If you have a genioglossus muscles, using oxybutylin or atomoxetine has reduced the AHI from 28 to 7.5. 37% who had low arousal threshold has responded to trazodone. 36% patient who had a very high loop gain has responded to acetazolamide, and 28% had multiple pathology, which you need to identify and treat them. Then we have a polysomnography based phenotyping, where we have mild, we have a periodic clean movement of the sleep, then we have a non-REM arousals, we have a REM hypoxia, we have hypoapnea and hypoxia, we have arousal and poor sleep, and then we have a combined severe. Periodic clean movement disorders and hypoapnea and hypoxia are associated with worse cardiovascular outcomes. Why? Because during the periodic clean movement disorders, there is gross desaturation, though the AHI is not very high. Let me show you this clinical study which shows that PLI, periodic clean movement, had an AHI which was around 10 only. So patient was falling into a mild category, but there was a gross oxygen desaturation. The gross oxygen desaturation, and that is probably a high link to the cardiovascular diseases. Let's go to the clinical phenotype. This patient is having obstructive sleep apnea, and if you look at he's using a CPAP with a pressure of 19. However, he has this intermittent central apneas as well. We changed this patient from a CPAP to a auto BiPAP. And when we changed it to the BiPAP, where we gave him a pressure of 25 by 20, however, the central apneas were still there, it was persistent. So that patient was behaving clinically different. Those patient who was diagnosed as sleep apnea upfront on a polysomnography, level 2 or a level 3 study, did not tolerate a CPAP or a BiPAP, right? And he was then diagnosed as complex sleep apnea. So whatever I said, I would like to summarize, and this is a fantastic cartoon which says the approach to obstructive sleep apnea. We all are using the one in the pitch, which is a CPAP, which is the gold standard, CPAP or a BiPAP, which is a gold standard. We are using the weight reduction, behavioral therapies. We are also aware of the sleep. We are using the oral devices and all. If you look at the outer blue curve, then there is hypoglossal nerve stimulation. Then whenever there is a loop gain problem, I'm sorry, how do I go back? Yeah. Whenever there is a loop gain problem, you use drug along with oxygen and the CPAP. When there is a poor arousal threshold, then you use a sedative and hypoglossal nerve stimulation, as I said. So this is a new approach after identifying a phenotype. So let's look at this. Any patient who has got a collapsible or a closed upper airway, what modalities you can do? You can do use a mandibular advancing devices or a tongue retainer, along with a hypoglossal nerve stimulation or an atomoxetine. If a patient has a low arousal threshold, you would use a CPAP along with a sedative. If a patient has got some anatomical problem like retrognathia or a macroglossia, which is a common condition where we'll see maximum macroglossia, which is a common condition in India where we see a lot of macroglossias. Hypothyroidism, right? So if a patient has got retrognathia or macroglossia, you can have a maxillomandibular advancement, you can have a mandibular protraction, and also you can use a PAP therapy along with that. If a patient has morbid obesity, you can think of a behavioral reduction of the weight or a bariatric surgery with a PAP therapy. If there is an overlap with obesity, hypoventilation, you can think of giving a BiPAP to the patient. If the patient has a complex sleep apnea, of course the servo works. Now we have the IVAPs, which would probably work in such patients. If the patient has got a high loop gain, you can give a PAP with oxygen with acetazolamide. And if the patient has a multiple issues, you can combine the therapy. You can use an oral therapy, you can use a surgical modality and a PAP therapy. So in summary, I would like to say that OSA is increasingly recognized as a heterogeneous disease. So my OSA is not like your OSA or not like his or her OSA. The DICE and the dynamic MRI are promising modalities for phenotyping, especially the anatomical phenotyping for the airways of the adults and the children. CPAP remains the gold standard for OSA, but alternative therapies are there for the 25 to 50% of the patients who have a compliance issues. The future of CPAP intolerant patients with OSA will likely revolve around the precision medicine, or that is personalization and combination treatment. So, ladies and gentlemen, in the end, I would like to end by saying the woods are lovely, dark, and deep, but I have promises to keep and miles to go before I sleep. Thank you very much.